Well, good morning, everyone. Welcome to the webinar. Today's topic is social determinants of health, and we thank you for joining us. These complimentary webinars are brought to you by through a collaboration of sponsorship with Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And my name is Kim Bailey, and I'm here at Alzheimer's Orange County and will be your host today. So, as many of you know, our sponsors are providing these webinars to you as a service to our community on topics that are beneficial for anyone who is working with or caring for older adults. We hope that you find today's presentation informative and useful. We have a wonderful speaker. His name is Dr. Neil Patel, and I'm going to tell you all about him in just a few minutes. But before I do, let me review for you on the next slide what you need to know if you're interested in earning CEs. So we do offer credit to our CFE, BRN, and CAMP under the BBS. You must be online for 60 minutes. You must have access to both audio and visual computer elements. Your link is unique to you, so you can't share it for others. If if you do and they attend, they're not able to receive CE credit. There are a series of poll questions. We'll ask you to answer them immediately. This is proof of your participation and is required for CE credit. If you should encounter any difficulty accessing the poll or answering the question, simply put your response in the chat box so that you will receive credit for the CE. There's also a required survey that must be completed and returned. It's going to pop up on your screen immediately following the webinar. If you're not able to complete that survey, there'll be another survey link sent out via email. So very important to complete that so that you can then receive your certificate of completion via email within 10 days of that completed survey being received. So just a few general rules for everyone. Your mic, your video, your hand raise feature, all of those are disabled. However, that doesn't mean you can't communicate with our presenter via questions that you place into the chat box. And we've carved out time at the end, as is our custom, for us to have a Q&A with our speaker. And so we're going to save those until after the presentation. Okay, let me now tell you a little bit about our esteemed presenter, excuse me. He is Dr. Neil Patel. He's a family medicine physician who's currently in private practice in Orange. He was born and raised in Orange County, and he completed his med school and residency in Southern California. He believes in the quality of medical care versus the quantity. So quality over quantity. And he approaches medicine in a holistic manner. Patient care has always been his top priority, and he continually strives to provide it at the highest level. So with that, I am going to go ahead and turn the presentation over to our speaker, Dr. Patel. Thank you, Dr. Patel, for being with us today.
All right. Thank you so much, Kim, for that warm welcome. So, as Kim mentioned, thanks everybody for being here. My name is Neil Patel, currently a physician, as we mentioned, in private practice in Orange. I'm family medicine trained, but I mainly focus on geriatrics. So, today we're going to talk a little bit about different aspects of the social determinants of health. Right. I'd like to start with a quote here. Poverty is the worst form of violence. Mahatma Gandhi. So, real quickly, right off the bat, I want to explain a little bit about myself. Like Kim mentioned, I am born and raised in Orange County my entire life. All my school training was done in Southern California. kind of a few places I went. UC Irvine. So I did my undergrad at Irvine. Medical school was at Western, so in Pomona. My residency was in Dignity Health, which is downtown LA. So I did get a chance to experience different areas of my training as well. Um, I chose family medicine mainly for its versatility. I can work in almost any type of medical setting, inpatient, outpatient, urgent care, consult, telemed, you name it. So I love to have that, and educational. I love to have that flexibility. And of course, as a general practice, you have to know a little bit about everything. So luckily for me, I find the body, mind to be absolutely amazing. So it's great. I have a little bit of knowledge on all of the different parts of the body and the mind. Of course, patient-doctor relationship has been number one for me my entire career and my medical school, and I still value that highly. And of course, work-life balance. So, just a background, we are going to talk about the social determinants. So, what have I experienced or where have I worked? So, I've worked a lot of different places in the past. I used to work for moonlighting, doing urgent care. I work with Social Security. I work with Veterans Affairs. I did urgent care, worked in different private practice. I did tattoo removal with Homeboy Industry. I did educational talks with my hospital, telemedicine, and my biggest job out of my residency was working at the LA County jails. So I was a doctor there in the Twin Tower facilities for about a year and a half. And then currently, as mentioned, I'm in private practice. So, okay. So, of all the forms of inequality, injustice in health is the most shocking and inhumane. Martin Luther King. So, who here kind of knows about social determinants of health, right? It's a very hot topic right now in medicine and probably just in general. It's becoming more of a focus in terms of how to maneuver the healthcare industry and how things are going to change in the future. To make it clear, social determinants of health by the World Health Organization is defined non-medical factors which influence your health, right? So think about where you're born, where you go to work, where you live, where you play, where you eat, how all those things can kind of structure our environment and structure the outcomes, especially for our health, right? So social policies, systems, things of that such. All right. So I guess we have a poll question here.
Okay, thank you so much. And our question is, a true false, social determinants of health are non-medical factors that influence health outcomes. Audience, is that true or false? Once again, social determinants of health are non-medical factors that influence health outcomes. Go ahead and quickly select your response. As I said earlier, if for any reason you're having difficulty with the technology, you can put the answer into the chat. We'll give it just another few seconds. And I think it looks like most people have had a chance to weigh in. So we'll release those results. And everybody did well. We did pretty good on that, but you'll learn more as we go along. So I'll turn it back over to you, Dr. Patel.
All right, great. Thank you. So let's keep going. So let's get into, I always like to start with history. Where did this come from? What is the concept? So social determinants of health actually started around the 19th century in America. This was during the Industrial Revolution. During this time, they saw a lot of increases in disease and poverty. So they started to put the pieces together and say, hey, this might be a problem for our future. How do we address it now? 1948, WHO, World Health Organization, is formed. Obviously, they wanted to include this social well-being as part of their beliefs, their morals, kind of their main focus. In 1960, there's something called the rise of barefoot doctors. Anybody heard of these doctors or familiar with that term? So back in the 60s, China saw a rise of these barefoot doctors who were medical professionals that would go into very rural places, villages, places where there's not access to a lot of healthcare, and they would provide any types of support and medical expertise as they can. So they help to urbanize kind of medicine in different locations outside of big centers. 1978, WHO director declares health for all by 2000. That was more to set like a grounded goal to make it easier for policymakers in the future, right? To create for the future. 2002, WHO establishes the Commission of Macroeconomics and Health. So that determines all these other factors, like we mentioned. And with the pandemic in 2020, COVID, the CDC focused so much on social determinants of health that they actually created this type of outline and guideline on what to do, how to kind of improve the different needs that we are currently facing. Well, obviously starts with individual all the way to the community. So, right, we start with ourselves, then you go all the way to policies and interventions. How do you keep on working on social determinants? How do you refine it and improve policy, infrastructure, community, partnerships, data, evaluation? So it's a big piece. So the whole goal of today is to see where do you fit in it and how do we continue the cause and improve this. All right, there's different categories here we're going to touch on. Education, economics, we'll get through all these. Greed has no boundaries, Aristotle. So one of the biggest social determinants is economics. So right off the bat, anybody know, these stats are a little bit on the older side, but in 2022, what do you think that the average household income was? Okay. Okay, so interestingly enough, yeah, that's about right. Yeah, 70. Okay, Tiffany says 650K. No, Quinn, about 60K. Yes, that is right, 70. So let's see. So yeah, so this is from the U.S. Bureau of Labor and Statistics. If you look here, the majority of people fell in around the $75,000 range per household. Look at all these other points. So about 50% of all households earn 75,000 or less. And then same along the same lines, what is the poverty level? In the US, the poverty level in 2022 for one person is 14,000, about 15,000. I'm in California. I don't know how anybody could survive with that type of salary for one person, even. All right. So very low standards. Obviously, California is a little different, but it just shows what the state of our economy is in the US. Okay, moving forward, income still. Who here believes in saving, or who here has saved in their lifetime, right? Ironically, saving is almost a lost concept to some level. So if you look at this green bar, this is from the Federal Reserve, by the way. This green bar, the average is what they would recommend is the number or how much money they have in the bank accounts for saving. But the actual is this. So look at what they recommend your savings account looks like, or account balance, and how much we actually keep in our accounts. So that entire concept of savings is lost to us, and that's a big issue because of unexpected expenses. Interestingly enough, poverty levels do vary, and in terms of different populations, Hispanics and Blacks tend to have a higher level of poverty than their actual population. Look at this ratio right here. Actually, American Indians, Alaskans tend to have the highest, but they're over one, the ratio. That means there's more people who are in poverty than there are people in general for that population. The poverty threshold was determined or defined in 1959. That's how long we've been kind of tracking poverty levels. And now let's get into employment. So throughout life, you can see throughout the years, there's different dips and peaks and valleys on unemployment. Usually you have unemployment that follows like a major event, right? 2000s, you kind of had the dot-com bust. 2010, the great, I guess, recession or correction, I should say. And then, of course, COVID caused a huge dip as well. Interestingly enough, healthcare, if not already, is slated to become the biggest sector for jobs now and all the way to 2031. I mean, if you think about it, we spend a lot of money on healthcare, and everybody will be involved in some way or form with healthcare in the future. So, as mentioned, employment rates do vary based on different races. Of course, total you're looking at around 4%, but different populations and races, blacks, Hispanics tend to have a higher percentage. 2022, 3.64% of the total workforce was unemployed, which is actually pretty decent. Food security. Anybody know about food security or what that even means? Everybody any heard about that concept? Well, food security from the USDA is defined as lack or insecurity. So for insecurities, lack of consistent access to enough food for every person to live a healthy and active life. Interesting enough, luckily, thankfully, a majority of Americans do feel food secure, 87%. However, it's still a big chunk. 12 to 13% do not feel secure where they're going to get their food from. Do they have enough money to pay for it? The different level of food security, right? Most people luckily have high food security, no problems. You start getting to low food security, you can't even eat properly, lack of money, lack of resources. Um, there's so many causes, right? Food, obviously, an essential part of life and existence. So, what causes it? A few things: housing, discrimination, trauma, and we're going to touch bases on some of these causes. Luckily, there are government programs that help, people who are in need. CalFresh is a great program. It's a monthly beneficial program. It's the largest food program in California. It provides basically like a safety net for food. Uh, of course, the WIC is pretty popular in California. Women's, infants, children. They focus on providing proper like prenatal care and helping the babies and children. EBT cards are like those government funded programs as well. You can use these cards to buy groceries and buy food. If you ever have any issues about resources, where to turn, 211, great resource here in California. They can kind of redirect you to different parts and places. Okay. Housing. Who here has heard of affordable housing? We're gonna touch bases on that in a little bit. Um, right, housing is a big issue. This is an older graph, actually, 2020. So imagine now, but this basically shows the number of renters who are low income. How many of them could they truly afford housing in today's market? California, only 23 out of 100 low income renters could afford housing. Versus if you look at other states, Ohio, Pennsylvania, Kentucky, definitely higher. Obviously, most people tend to want to live on these states. Interestingly enough, like mentioned, look at 2011. Number of units available at the rent price were a lot more reasonable. A lot of rents, $1,000, 1,400. Now all of a sudden, fast forward 10 years, there's really not that many apartments with these lower income or these lower rent rates. All of a sudden, you're getting a boom in these huge overpriced units, and that's causing a lot of strain for people. As always, California does have a lot of good resources. California Association here of realtors has a housing affordability fund where they could help cover up to 10,000 for first-time homeowners closing costs. Housing is Key. It's a California program as well. It's meant to help with rental assistance, mortgage, eviction. Of course, a housing and community development is also important for California. Okay. Education is the most powerful weapon which you can use to change the world. Nelson Mandela. So literacy, right? Who here feels that America or California is literate or up to date? Do we feel we're educating our children? Do we feel we're educating our citizens adequately? Well, maybe not so much. It's sad that a first world country even has 70%, 80%. We should technically be above 90 across every state. Ironically, a lot of states don't have that threshold. So the question is, why does California, for example, in New York, have such low literacy? And that's sometimes due to we do have a bigger population of immigrants, migrants, different backgrounds, so that can affect it. Okay. This is old. I really was trying to find a newer one, but as of 2003, you can see the difference percentages of those who have literacy and illiterate options. Okay. In general, less education leads to lower income, leads to poor health. So this is all connected together. Just make it simple. More education, the healthier you're going to live. The higher your education, less likely you're going to have a job with safety risks like construction or heavy lifting. Okay? The goal is obviously to improve education across the board. Now, interestingly, like I worked in the jail system, so I've seen it firsthand. But prison, right, as you can know, a lot of people who are incarcerated in prison jails, they have a lower educational rate. You can see from these different graphs. So there is definitely a difference in the way it affects society. Some statistics. This is from the Kaiser Family Foundation. I'm not sure if you've heard of them. Now, the Kaiser Family Foundation has nothing to do with Kaiser, the healthcare system, hospital system. It's a foundation, it's nonpartisan. It's basically meant to focus on health policy. So they do a lot of great data and research that's not biased. Now, it's a little bit older, 2021. They saw that limited English proficiency by age, race, ethnicity, and state and language. So obviously, California, Texas tend to have the highest rates. All the other states combined for the 42%. The biggest thing, of course, Spanish is a huge language in not only California, but I think it's the second most spoken language in America. So it's very important to understand or try to make sure you have the right resources to help those who only speak Spanish. Language, as mentioned, right? People with limited English proficiency. Obviously, the 35 and 54. So they're the biggest gap, actually. Biggest group of people who are not literate. Of course, the other gap is 1934. So if we can focus on these two ages, I think we can definitely help overall. Interestingly enough, you can see here barriers faced by female immigrants. 20% of children are born to immigrant mothers. 33% of the hospitals fail to provide a translator. So something that simple can make such a difference. Right? Limited English as well. So the same thing, language, right? Which groups are most affected? Hispanics, Asian, then whites and blacks. So right off the bat, like we mentioned, right, we said Spanish is a very common language in California. What about other languages? Any ideas on what other languages show up in California or what you would think? Okay. So look at this map. So Spanish across the board mainly is the most popular language, but look how many different languages are in California. So it is so crucial to have a translator, have a system in place to make sure you have, proper translation and can help your patients or whoever you're serving, clients, residents, whoever it may be. Over 200 different languages are spoken in California, and about 40% of Californians speak different languages outside of English. Okay. So childhood is a huge part of kind of education and how we're up, how it can affect our quality of life. Anybody heard of like an adverse childhood experience? Okay. So unfortunately, this is relatively common, but an adverse childhood experience, basically where you experience some type of trauma, whether it be emotional, physical, drugs, you name it, in a child's life, especially during the time they are developing, especially younger kids. Okay, so some examples: physical abuse, emotional, substance abuse is a big one. Suicide, of course. Trauma is huge on the system, especially when we're young. It can kind of rewire your brain to become stuck in like this survival mode and create unnecessary fears. And unfortunately, like I mentioned, this is pretty common. 64% of US adults say they have experienced one type of event before the age of 18. Obviously, these types of events can lead to increased risk of, anxiety, depression, mood disorders, poor sleep. So it's interesting. So those who make more money obviously have better quality to care in terms of their kindergarten or their even their education for their kids, right? It depends on income. So the more income you make, maybe the better options you have, and then the race, right? Different races have different allocations and distributions of where they are putting their children. So vocational also big. It's good to see, this breakdown of where do different races, different populations work. What type of jobs usually? If you notice, usually in terms of whites, more management, Asians also more management. Service is pretty big across all four. In terms of Hispanics, blacks, and African Americans, they have a bigger rate of sales, sometimes transportation, right? So you can see the distribution in terms of where do different groups work. By 2030, about 30% of the workforce will be Gen Z. You remember what Gen Z is? Gen Z is late 1990s and early 2010s or 2000s. So everybody's kind of confused. How is this going to play out in terms of the new generation's thought process on how to work, their thoughts, okay? Right? Sadly enough, this 2023, nearly 1 in 10 employed Americans are very worried about their job security. So that's a very stressful thing to have to deal with. Interestingly enough, of course, people want that work-life balance, like I mentioned. How do you achieve it? Well, most people are willing to take the higher pay and have poor hours if they can get paid more, basically. So this is a really interesting kind of survey to see what do people value and what's important to them. Higher pay across the board, hours, work from home, job security, all these things start to add up. Okay? Millennials are also the most worried about their job security than any generation. They say 42% are worried. Workers tend to prioritize their paycheck more than benefits nowadays. Before, you could say, hey, we're going to give you smaller salary, but look, you're going to get time off, you're going to get healthcare insurance, you're going to get all this stuff. Nowadays, people are not as inclined to get that. Nearly a third of workers say they're likely to quit their job in the next 12 months. So that's very important to see the stability of the economy as well. Sometimes it only takes one act of kindness and caring to change a person's life. Jackie Chan. Okay. So access to care, right? Anybody think about how do certain patients, how do they even have access? Do they have access? So physical access, are you in a place where you can actually go to a hospital, go to a setting? And also disabilities, right? So how many disabilities? So if you look sadly, statistically speaking, American Indians have a lot of people with disabilities, 3 out of 10. African Americans 1 in 4, Asians 1 in 10. And you can see what is the main cause? Mainly smoking and weight. That across the board, honestly, is going to affect every person, every race at this time. You look here, 46% of Americans have a disability, pretty evenly distributed, males, women. Um, the age, of course, as you hit 75 and older, it increases tremendously. Oh, let's go back real quickly. Most common type of disability includes walking, independent living, and your cognition. Cultural. We kind of talked about the different languages spoken in California, but what do we do? How do we break these barriers, right? So important that you're aware, social norms, right? Shaking a hand is fine in American culture, it might not be in a different culture. Taboos, values, power, how do they value and how do they observe power? And of course, stereotypes. Interestingly, Medicare, older Hispanics are under the assumption Medicare is going to help them pay for like a lot of their health issues, including long term care, where Medicare does not pay for that. Only 2 out of 10 say they're confident that their health aides, nursing homes would be able to accommodate their cultural needs. So imagine that you already have health issues that are not being addressed. Now your own personal needs or cultural needs are not being addressed. So this is very important for us to work on. And now we're going to do another poll question here.
All right, everyone. Our next poll question, again, a true false. Most people are not confident that their cultural needs can be met in medical settings. Is that true or false, attendees? Most people are not confident that their cultural needs can be accommodated in medical settings. Go ahead, everyone, and select your answer quickly. So once again, we can return to the presentation. We'll give it a few more seconds. Most people are not confident that their cultural needs can be accommodated in medical settings. Let's go ahead and release those results. And it looks like you did very well on this one. Congratulations, and back to you, Dr. Patel.
All right. So let's move on. Okay, we're going to get some. If you cannot feed 100 people, then just feed one, Mother Teresa. So let's talk about environmental housing. So we briefly touch on it. Housing is a big issue right now. What is affordable housing? You may have heard about this term. It's super hot topic right now in almost any field outside of medicine too, but it affects our healthcare. Right? Affordable housing is what they say is defined as the government and the family does not spend more than 30% of their income to live there. I'm bringing this chart back up. Obviously, can people afford it? Not really. 24 out of 100 people with low income household cannot afford housing in California. So what do people do? Hence, you have such a big, so much discrepancy and an increased rate of poverty. 8 out of 10 households with low incomes have unaffordable housing costs. More than half of renters pay over 30% of their income toward housing. And that was back in 2017. So imagine now. Housing is a very complex thing. It's how do you make it more affordable? What do we do? You want to create that equity in place, develop a systemic change. So this takes all of our help. Yeah, you're going to preserve the house itself, make sure it's still functioning. Placement, where to place them, where would they be the most comfortable? Obviously, make sure it's safe and protected. How to probably produce new housing and locations, and of course, the power. How to make sure that everybody's respected and feels heard. More than 2/3 of Californians with unaffordable housing costs are people of color. And of course, in most serious cases, unaffordable housing can push households into homelessness, like we talked. So it's a very interesting like system. The housing continuum. How does it even work? So, really sadly, we're thoughts and prayers to all of the families here in California with the fires going on. So if you think about it, for those unfortunately who may have lost their homes, they had a house, now they may be back all the way here. You go from having a house. For those who are homeless, you go into emergency shelter, temporary, transitional, supportive housing for those who have like substance use disorders or drug issues, subsidized affordable, and then affordable housing. So it's quite a spectrum at this time. How do we efficiently kind of stratify all of these different fields? Food, of course, we talked a little bit about food security. However, luckily in America, we have a lot of programs. SNAP program, like what we talked about earlier, is like CalFresh, Supplemental Nutrition Assistance Program. So you can see how big of a program it is. So obviously, there's a lot of help for those who need it. This is probably the most eye-opening kind of stats here. Fast food consumption is up from 2018, 15, 18. This has probably gone up even more since COVID, right? DoorDash, and I used DoorDash recently for the first time, and it was just mind-boggling that I can just click a few buttons on a two-dimensional phone and the food just showed up. It's just phenomenal. With that convenience, though, you get these types of stats. More kids, more people are eating fast food. This is by far probably the most concerning stat. This affects everybody. Obesity in the US is increasing at a very alarming rate. In 1 year back in the 2000s, 30% were obese. You fast forward about 20 years, 42. You fast forward another about 10 years, the stat shows that over 50% of all American adults will be not overweight, obese by 2030. So that will bring its own set of health concerns and health challenges on how to maneuver the healthcare system. Average percentage calories from fast food was higher though among African Americans and Hispanics. 2030, as mentioned, 50% will be obese. So water, we talked about food. Obviously, right now, water is a huge topic, especially here in California with, I guess, fire hydrants, things not having water. This kind of talks about this map basically talks about communities where water systems are in violation, right? So what areas the water systems are not up to date? I mean, California is pretty much up to date. You got a lot here in New Mexico, kind of Midwest per se. Overall, pretty good. This is a website, another website, Cal Matters. Great website, CalMatters. It's got all these stats that talk about drought, water situation, where we're at with the current, how much water do we have? This is an older stat. Over the past 365 people, look at that, 520 households complain of water shortage. So we can see. Interestingly, 2022, 41 million Americans struggle to pay for water. So you can see just how much the water bills have increased. And the price of water, right? You get a water bill, but what does that really entail? Price for paying for the water itself, treating the water, sewer prices, storm water, all this stuff is added in your bill. This is old, 2015. I couldn't find a newer one, but back in 2015, LA 136 was what they're paying for a household per month. 326 was the average per month. That's a lot for Atlanta. 12% of homes, water bills are too expensive. So going back to Atlanta, if they're paying $300 a month, that means if your household income is like 32,000, you're paying about a 10%, 3,600 per year just on water. It's way too high. Sadly, there are no laws that guarantee water access for poor Americans. So we don't really have a place. We got food access, but not water access. So everybody, of course, is trying to figure out what to do, the next steps, nitrates and nitrites. I'm not sure if you heard about them. Kind of like these chemicals associated with agriculture. They can impact your body's ability to carry oxygen and cause, increased risk of cancer and different issues in the body. One Water Approach is this nonprofit kind of organization that's trying to create a system on how to change the laws and regulations around water, right? Including drainage, protection, livable needs, how to secure a proper and healthy resource. Right, the goal is to reduce water imports by 50% and use local resources by 2025, 2030. I am a reflection of the community, Tupac Shakur. So let's talk about the community. Now, this is all a very big part as well for social determinants. Violence. Violence is a very hot topic as well. Unfortunately, it happens quite a bit. There's just some cool, interesting stats from COVID. The UC, University of California, Davis, does a lot of extensive statistics and research on these types of things. If you look at the violence in firearms after COVID or before COVID, you have still violence and crimes, but after COVID, everything almost increased. Homicide rates, mass shootings, police violence, you name it. So there was some hysteria, concern with COVID. People did not know how to react. Interestingly, 1.1 million men and 400,000 women report that they committed at least one form of sexual harassment. Not that they were victims, but they committed back in 2022. Right? Number of these programs for sexual harassment have shown to improve and reduce violence, especially repeat offenders. So there's a lot of importance to put investment in that. Some statistics, right? 1 out of 6 have experienced some form of violence in the past year. About men are more likely, were twice as likely to report, some type of violence the last year. It shows just how many people, 1.1 million adults, were assaulted or abused by their partner. Going back to firearms as well with COVID, guns, right? Why did people buy more ammunition? Why did people buy more firearms? They were worried about laws, prisoners being released, all these different things, like an apocalyptic episode. 2 out of 5 were new owners during COVID time. It's a lot of new people. Of course, right? Those 13% of adults were concerned they knew somebody that might hurt themselves. Okay. 1 out of 5 adults, 6.5 million are concerned they know somebody, usually a friend or family, that's at risk of harming themselves. So this is a pretty widespread problem and affects everybody. So for those who are, of those people perceive that being at risk for harming others, 19% of those have firearms. So 1 out of 5 of those who may hurt somebody have firearms on top of that. So back to the UC Davis info, knowing someone doesn't make a difference, right? You're more likely to, if you know somebody, they're more likely to be the ones for causing the violence. Border experiences were pretty traumatic, or broader experiences were traumatic as well. Right, interesting from California, you can see 2 out of 3 reported at least one experience of violence. You can see how the percentages throughout. 3 million know at least 2 people were at risk. It's quite a bit. 2023, California ranks 17th in national violent crimes. Racism, still a big issue, still exists. Fewer Californians say it was a big problem, but it was still a problem. You see here where African Americans are most likely to experience some type of racism. See the different percentages, discrepancy, right? Yes, regularly. Asians, maybe some. Whites tend to have the lowest amount. 4 out of 10 say they have experienced discrimination. 6 out of 10 say they have not experienced it. So it's interesting. This poll was taking a couple years, 2022. Responding to racism, how can it affect Black patients to choose, sadly, their respect or care? So they're put in such a tough position. They might see a professional, a doctor, whoever, and they're not respected. So all of a sudden, interestingly enough, you're getting 32% of African Americans saying they've experienced racism. 59% say racism caused them to stop or interrupt their treatment. That's very unfortunate that something like that makes them stop their own health. Now they're not only feeling comfortable, feeling comforted, they also are not being treated. In medicine, there's the diversity, or the split. So the goal is trying for them to push more of different groups to join medicine, promote it. Black and brown physicians are a little bit more questioned and than other doctors. And we're going to do one more poll question here.
Okay. And that poll question is 32% of African Americans say that they've experienced racism while dealing with the healthcare system. Once again, about 32% of African Americans say they experience racism while dealing with the healthcare system. Go ahead and um, respond to this question, and we'll give it a few seconds, and then we'll release the results. Once more, we're asking if it's true or false if 32% of African Americans say they experience racism while dealing with the healthcare system. All right, let's go ahead and take a look. Okay, it looks like everybody got that right, or at least we were all thinking along the same lines. Was that right, Dr. Patel?
Yes, that was right. That's correct. So good. All right. So yeah. So obviously, a lot of like we mentioned, African Americans disproportionately have experienced racism in healthcare. So let's move forward. To remain silent and indifferent is the greatest sin of all. Eli Wiesel. He was part of the uh, entrainment camps for the Holocaust, not for World War II. So the idea is, who cares, right? We talked about all these stats. I threw so many different stats at you. Uh, we talked about so many different factors: education, housing, financial. Does it really matter? Who cares? Well, we should care because it's going to affect us all. Number one, United States has the worst life expectancy in like a first world country and the most spending per capita. How is this happening and why is this happening? All right. So like let's just look at United Kingdom. Better life expectancy, less spending. France, Switzerland, Japan, obviously, same thing. So, um, 2021, 18% of the US GDP or $4.3 trillion was spent on healthcare. That will continue to grow. Spending was more than double for other countries. Right. So, this is a big question. Why are we spending so much yet having poor outcomes? So if you look at US, it's always an outlier. They spend more, life expectancy low. Obesity rates higher and they spend more. Diabetes higher and they spend more. Infant mortality higher and they spend more. The overall mortality versus other countries is higher. So, people ask why. COVID-19, they think that's part of it, but this has been going on for years. Obesity now is becoming an issue. Also, healthcare in general is expensive in America. And just the way we eat, our exercise, our lifestyles are basically fueling chronic diseases. And then what happens is a lot of these diseases are just managed, not cured per se. We just manage and keep treating it without any major changes. Interesting enough, 2023 out of 10 adults, US adults, have been diagnosed with two or more chronic conditions: diabetes, depression, heart disease, blood pressure, you name it. Okay. Right, you can see the changes in the consumer price index. So you can see the ups and downs of pricing for medical, how medical care continues to kind of go up as well. 25% of healthcare budget goes to waste. That's a huge part of us with poor spending. What is it like from 2019? Administrative waste, huge. Obviously, fraud and abuse does occur still. The admin, how do we get rid of this? Operational waste. So this is something different sectors we have to work on to see how we can kind of shrink and narrow this gap. Healthcare costs, right, tend to increase. They continue. 5% of our GDP, now all of a sudden 20%. Why such a big jump? Well, the same thing. Our food quality has gone down the drain. Our lifestyle, and the truth is, the pharmaceutical industry has fueled all this as well, and insurance companies. Most importantly, this is the biggest thing: the U.S. population 65 and older, predicted to reach 20% by 2030. Have anybody heard about the silver tsunami? It's basically a little term that tells us how we are aging rapidly. About every day, 10,000 Americans turn 65 every day in this country. So imagine how this is going to affect the healthcare system, not now, the next 20 years. As those 65-year-olds turn 75, 80, and beyond, we're going to start to see some strain on healthcare. And Medicare, like we said, is expected to grow, I don't know, substantially or exponentially, which word, because we don't know what's going to happen. Medicare most likely will run out. We're going to have to find an entire new system uh, at some point on what we're going to do. So, this is pretty eye-opening. In the next 20 years, how are we going to be able to manage and afford this and keep our citizens and everybody healthy? So I had a patient sometimes ask me about just cash pay. Forget insurance. What if I want to go get something done out of pocket? Number one, sometimes a lot of people do allow that. Sometimes they don't. MRIs can depend on what type. They can vary. I've had patients pay for like the 500. I've had patients pay a couple thousand if it's more detailed. X-rays depends on where you do it. They can be relatively cheaper. Blood tests, cholesterol. So price points vary, right? You're hoping to make it cheaper because even if you go through insurance, sometimes they don't cover it anyway. Medications, of course, can vary quite a bit. You can see the different price points. Emergency care, God forbid anything is to happen, you definitely want to have insurance for this purpose because it be very expensive if you go to ER out of pocket. Up to 20,000. Ambulance can be like 1,500, 2,000 for a one-way trip. Air ambulance is huge. That's a whole different. I had one patient who had that, but luckily he had insurance. Family planning, right? Having a kid, taking care of a kid can be expensive nowadays. How to prepare. Luckily, most insurance covers all these costs, but this is just to show you what it can be like if you don't have insurance. Surgeries, of course, can vary, right? Coronary can be huge. Most expensive is cancer. Cancer treatments are very expensive because they're very specialized drugs, very hard to create, very hard to form. The biggest issue is also with Medicare is it's inflation, right? You've seen the news how economy right now is not doing the best. There's inflation. But look at this. This orange line is supposed to be what payments should be when adjusted for inflation. So back in the 2000s, let's say I saw a patient, I'm getting paid maybe 40 bucks, right? Technically now 2020, I should be getting paid 70. But the actual thing that's happening is the opposite. So if I got paid 40 bucks or whatever, 40 bucks here, 2022, I'm getting paid 35. I'm actually losing, getting paid less over time. RVU is something that's used in Medicare to determine, it's called relative value units. It's like a way to mathematically determine the amount of value you've provided for that visit, that office visit for a patient. 2023, that conversion factor is 33, 24, 32, 25. I think it's 32 and 0, 0. So it's continuously going down. This is a very eye-opening, especially for those on this call who are in the medical field. Inflation, just from American Medical Association, inflation has gone up, right? We know that. That's expected. That's part of all economic trends over time. Practice cost, the amount to cost to, I have a private practice, it can be pricey. Look at physicians. Their costs, their reimbursements have not really gone up at all. They have actually been stagnant. Look at that stat. adjusted for inflation, Medicare payments have declined 26% from 2001 to 2003, whereas inflation has continuously gone up over like 60, 70%. Medicare already cut it by 3.4%. They cut another rate in 25, I think like 2.5% for 2025 schedule. So they continuously keep cutting it. So what does that mean? Doctors are getting paid less. The patients who have Medicare, their premiums keep going up and fewer things are covered. So I know there's a lot of stuff, what to do, right? We all want to make a difference. We want to help each other. How? CMS, Center of Medicare and Medicaid, great place to start. There's a lot of different groups within this organization that you can be part of. You can take action. You can get involved. I recommend you do, just because this will affect everybody. Doesn't matter what part of medicine you're in, even if you're not in the medical field, health affects every human regardless. So it's better to be on top of it than to wait and see. Right? This is the overall idea of how to do healthcare in the future, right? Social determinants, equitable access, how to transition. So it's how to create a system that's more effective for everybody. Health equity is means, does everybody have a fair opportunity to just to get to their healthiest? Healthcare equity, do people have access to healthcare equally to help them get to their highest level of health as well? So get involved. So many different places. Patient advocate, consumers, even all of these different foundations, you can get involved and just say, hey, I want to participate. I want to be involved. Because of me as a doctor, we are involved with California Medical Association, AMA, so many different and great resources. Okay. Wherever the art of medicine is love, there's also a love of humanity, Hippocrates. So as doctors, as providers, we take the Hippocratic Oath. So I really hope that you do practice and believe in that. So I want to thank you guys for your time. I know there's a lot of info, but hopefully it was eye-opening and you learned something. Oops. I'll show you some of my info here. If you feel free, you can use my website and my email if you have any questions. And I'll open this back up to the public.
Thank you so much, Dr. Patel. That was really sobering and eye-opening. I know all of us think about these factors from time to time, but when they're accumulated, you know, I'm just thinking how blessed some of us are, to live in a good environment, to have access to fresh food, got that roof over our heads, access to education. And we really were able to see today how when you have low access to all of those things, it really can challenge your mortality and your health and emotional well-being. So thank you so much for informing us about all of that. And I want to, before we go to questions, I want to take a moment just to thank our sponsors once again, O'Connor Mortuary, Care Choices, Hospice and Palliative Services, Caring Companions at Home, and also, of course, the Alzheimer's Orange County. I also, with this topic, even more than most, we want to remind everyone of the importance of being aware of implicit biases or, unconscious stereotypes as we care for others. And so we know that a best practice is a person-centered approach where we view each person that we care for as an individual with unique needs and preferences, treat them with dignity and respect, even when they're very different from ourselves. So if we always listen carefully and respectfully so that we can understand their perspectives, values, and preferences, we can then build trust with our constituencies and provide the highest quality of care. All right, so let me check the chat box. You gave us so much information. I'm not sure we have a lot of questions today. Someone was asking how we as individuals can help uplift others impacted by these social determinants. And I believe you addressed that with the CMS strategic plan and some of the other agencies. Is there anything else you want to offer
Yeah,
to?
like I said, real quickly, these are the resources, but you may even start like grassroots. You start at your local office, your city, county, and just start there, right? You got to start somewhere. First place start is your home area. So even that's another option besides these types of organizations.
Right, even small steps can make an impact,
Correct.
right?
Yes.
Uh, Another of our attendees is commenting that things seem to be getting worse, not better, so we have to work harder to protect ourselves and others.
Mhm.
And we all are all on this call, everyone is responsible for the care of others. And so again, your words today have made a big impact. I want to mention while I'm thinking about it, just for those that have to leave the call, that next month for this webinar series, we are welcoming a guest speaker from the National um, FTD Association, and he's going to be talking about frontal temporal degeneration, how it's often misdiagnosed and frequently misunderstood. So mark your calendars for Tuesday, February 11th for that webinar. And then we also encourage all of you to visit our website at www.alzoc.org for the many education offerings that we have. And we have a question. You touched on this a little bit. Can you elaborate what we can learn from other countries in regards to our approach to healthcare in America? Meaning, can you give any specific examples of how other countries are doing much better than us?
Yeah, that's a big question. Is why are we not on par? Like I said, I mainly focus on geriatrics since that's my main niche per se. So just kind of focusing on that. Like a lot of countries around the world are having this kind of I don't know because it's a problem, but the situation where their population is aging. So Japan, that's actually a big focus because a third of their population is over 65 now. So the idea is we're trying to learn from them. How do they make their system efficient? How do they make it cost friendly as well? Right. So we're looking into if they're creating different programs. Like UK has more of a whole country, like a socialized program for health. So it makes it cheaper, but their outcomes sometimes are not always the best, especially for like cancer and things. So we're trying to kind of put the piece together between being effective and efficient and yet still timely. So those are two things we're trying to study from these different countries.
Great. Thank you for that, Dr. Patel. I had a question. You were talking about the physician reimbursement rates and how those are decreasing instead of increasing. I'm sure that must be one of the factors that for why we're having such a physician shortage in this country. Are there other factors at play as well?
Yeah, there's a couple of things. Physician shortage is a whole different situation. Partially it is because I don't say Medicare, but just they're not really incentivizing people to get into medicine, right? Because of the red tape and all the paperwork. Now, the other issue is like I'm primary care and I love what I do. A lot of medical students who go into medicine are mainly focused on specializing. So what they're doing is I don't want to deal with the diabetes. I don't want to deal with cholesterol. I just want to operate and I want to only work on the heart. So now all of a sudden you're getting piecemeal and broken care. So a lot of these patients use the urgent care and the ER as their primary care. And that can rack up costs like crazy as well. So those are some of the factors is the motivation and and incentivizing and encouraging primary care because we are the front line. And
Mhm.
if we don't do something, you know, you're going to get piecemeal and broken care anyway, which will create more of a burden on the healthcare system.
Thank you, Dr. Patel.
Mhm.
Okay, well, that brings us to the conclusion of our webinar. And we want to thank you so much for your sensitive and informative presentation, Dr. Patel. We hope you'll come back and see us sometime in the future. And to all of our attendees, thanks for being with us today. And as we close the webinar, as I mentioned in the beginning, you'll have a pop-up survey which you are required to return if you're getting CE. Of course, if you're not, we still love to have your feedback because we strive to continually improve this webinar series. So thanks everyone, and I wish you all good day.